So each time we do the lab, we try to add something that's a little bit different and I think brings good information. And so I've asked the scrub teams from our surgery center just across the hill to come along with Scott, who scrubs here at Swedish. So Scott scrubs on complex neuro cases, complex neurotology, all the way down to simple otology. And then our surgery center is a whole potpourri of otology, osteoid implants, cochlear implants. And it's kind of your chance to ask them what they think is important in the operating room. And I think their perspective is very important because otology, and even to a certain degree in rhinology, your team has a lot to do with your outcome. And I don't get worked up very much in the operating room, but when I have an open foot plate and ear filling full of blood, I don't have time for Reggie to be fooling around finding a prosthesis. And he's always right on top of it, Leigh's right on top of it, so that we prevent that. And at the end of the day, we have patients who get great outcomes and have a very good experience. So Leigh, if you could start, just introduce yourself and how long you've been where you are, and we'll go right down and then we'll fire some questions at y'all.
Hi, my name...
Just go ahead, just a little closer.
Okay. My name's Leigh. I've been at Minor and James Surgery Center for 10 years now. We've been per Alliance, I think, since 2016. And I was doing ear surgery prior to Dr. Backus coming. But I came into that situation with no ear experience in my career, so I learned along the way. But the volume that we've done with you has really upped my knowledge. So, and this is my cohort, Reggie.
Well, hi, I'm Reggie. I've been doing this for about 26 years at Minor and James. I used to be in the military, so I learned everything through the military. Dr. Backus came and we opened our eyes up to how surgery should be and how many cases we can get in through a surgery center, but it's really difficult and it has to be a lot of coordination with your nurse, everybody, so it's very fun.
Good afternoon, I'm Scott. I've worked here at Cherry Hill for 17 years, and I've worked with him for, I don't know, 10 or 12. I should get some sort of award.
It's like a century. Yeah.
But I've done a lot of his scrubbed a lot of his ear cases, and we've learned a lot of stuff.
So from a scrub perspective, one of the things I always try to do is I'll ask for an instrument a step ahead. So we try to stay 2 minutes ahead so people can find things. Is that good or bad?
Well, I wrote it down on my notes, prompt way before needed. So I think that must be important to me.
You can talk into the mic.
Oh, okay.
Yep.
Well, for me, I do like a few instruments ahead of time, but I feel like if you guys are going to do ear surgery, you should teach your scrub tech what you need. And some scrub techs really don't know the instruments. So if you teach them what your instruments are, your main instruments, and then give them 2 instruments ahead of time, your cases will go much smoother. But I pretty much know what instrument he needs before he asks me for it, though.
Leigh, when we're looking at picking up prostheses and things, I know it's got to be a bit aggravating when we ask for one thing and then we need another one like yesterday. Mm-hmm. So how have you kind of organized the OR to compensate for that?
Well, we have a consignment system with our Grace medical implants, and it's worked out really well. I've got the phone number of my sales rep on the box. We have a consignment. If we're able to see our schedule a week in advance, I look and I make sure we have enough. We had one day where we had 4 stapes on and we were only keeping a par level of 3. So a week ahead of time, I was able to get on that, up our par levels to 5. And then I just send her a picture of the box every time, every case, and she replaces it. It comes in the mail. But knowing ahead of time what the cases are really helpful. And sometimes it lists 2 or 3 or 4 procedures until you know you're in there and which one it is. So you just have to make sure you have those things waiting and be able to change on the fly.
So one of the things we do is, the operating room instruments, the micro-instrumentation, is very difficult to see a lot of those instruments in the dark. And we've taken all the sets, Scott, we started this at Swedish, we've labeled all the sets. Because unlike at Minor and James, where you have the same team every time, Swedish, it can be somebody very different. And what I've learned about people who scrub in the operating room and circulate in the operating room is they're all just trying to do a really good job. and they're all trying to please you, and it's really easy to get frustrated in a surgeon, but you're thinking about what you're doing long before you're asking for things typically, and it creates frustration for the staff. So the other thing we've done, Scott, which we started at Swedish, we do at Minor James, is we pick out a subset of the instruments that we use all the time and try to give each instrument per step so that you can get those quicker. What was it like getting the OR to kind of standardize the equipment market? Has that been helpful? What was the process?
Definitely. The more information we have, the better off we are. If it's labeled, we don't have to memorize everything. Some of these instruments we don't use quite as often. And, if it's labeled and you're like, okay, you go down, pick it up, boom, it's there. Anything we can do to keep the flow going is all.
So if you really sit down and think about the operations you do a lot of, you probably use between 5 and 10 instruments. So what we do is we pull those 5 or 10 instruments out and put them out on a separate table, and then the other instruments sit in the back. So Reggie, you kind of set your own instruments out now. Has it been that repetitious?
Well, for me, I knew exactly what you wanted, and when I worked with Dr. Hoistad, I knew what instruments he wanted. So for my prono view, I knew that if I put a rack and I had all your main instruments in it, that I knew that I could do your surgery with those instruments, and that I could keep up with you because I know where they're at in my rack versus where I have to turn my back and turn my back to the surgical field, and that's when you slow down at.
So Leigh, when you look at the morning schedule, what kind of goes? What are the things you're looking for to prepare the day?
Provided all the supplies are still coming in a timely fashion from when you order them, making sure you have enough fluid for the canisters. You're going to keep up with the irrigation system. We try to load our cases all the right sides first or second, just clump them together because you have to switch the microscope every time, so we don't want to go back and forth, and that takes a lot longer to turn over the room if the tech's doing it. Fortunately, we have Alex, Dr. Backus's fellow, who will assist with that as well, but if you don't have the fellow, your tech's doing it, and sometimes it's difficult to get that balanced. And just the turnover. We shoot for 15-minute turnovers. It's more like 20, 22, because we have 2 sets of instruments. So we talk very closely with our instrument tech to get them cleaned and turned over in a timely fashion so we can just keep going case to case to case. So, and then sometimes we bet each other what time will be done at the end of the day. Once that's out of the way, we're good.
So one of the things we try to do on the scheduling side is balance the day to so our average Thursday at the surgery center is 5 cases. And they can be 5 mastodectomy cases, a mix of cochlear implants and mastoid cases and stapes. What we try to do is actually mix the day up and vary the cases so that it's not 5 2.5-hour cases. So we'll do like a Baja or a Ponto, and then we'll do a cochlear implant, then we'll do a chronic ear. And the more predictable cases are the cases that balance the day's schedule. So a cochlear implant's very predictable. A temp mastoid is very unpredictable. And it's usually the temp mastoids that kind of knock us over a little bit. But I think the right and left issue is very important. And the other thing that I pound into our fellows is the surgeon has got to know how every piece of equipment in the operating room works. Because the staff do, but if one of them is tied up and the turnaround is based on that, we just step in and help you turn around. And what I love when doctors sit in the doctor's lounge and complain about turnover. They could be in the room helping turnover happen, right? So for Reggie and Leigh, when you know a case is coming to an end, I notice you're starting to break things down, moving things out. So when we start the case, I say, look, I need the bovie first. We need to have suction ready to go. So we give them the things we need in order so we can get started while they're setting up. So it's a dynamic process. But how do you know when to start breaking things down?
Well, when you ask for your closing suture, and but like when we're doing a cochlear and we have to take an X-ray at the end, and we maintain sterility for some of the cases when we're not certain they're in the right spot. So I'm ready, I wait, I take the pressure off the bag, I might unhook the drill so Reggie can get the cords off the field. But I'm standing there watching and asking, and can I turn off the NIMS? Can I do this? Can I do that? And I assume when I can do things, but I always have to ask, so I don't assume too much. But he's not kidding when he and Alex totally put their hands in. They take the microscope drape off, they undo the chair elbow pads, they put on the covers, and he's right there. They're right there. Alex gets the bed. It's a real team. It's not, oh, this is your job and I don't do that. We appreciate you. So
Good. So Scott, you'll have a room where you'll do a stapes and then a 4-centimeter acoustic and then a cochlear implant. So how do you fluctuate back and forth in that, and how do you coordinate with the team that does the turnover at Swedish? How do you try to get that set up? Do you meet in the morning and talk about it? How do you do that?
We study that.
You got to speak in that.
Oh, yeah. We study that schedule, our paper schedule, very closely. And I was going to touch on that. If you guys spend a minute or 2 minutes beforehand and look at that schedule for the next day, and every word, we look at every word because sometimes words are spelled wrong and we're all like, what does that mean? And it's like, I don't know. And it's a misspell or something like that. We study that 2 minutes you guys look at that schedule, what you guys want, will save you 20 minutes or a half hour or even your case sometimes, because we might not have something if it's not on there. And I was going to say one more thing. When we start closing, yes, we start breaking down, but that's when I ask you, what's the next case? Anything special about that next case? Because you're a little more relaxed, you're not just closing, and then I can get some clues, if they weren't on the schedule, that we can correct or get for you before you even are in the room for the next one.
So just for giggles, we were trying to figure out, we had a situation about 5 years ago, at Swedish, where I put a Med-El cochlear implant in a patient that ordered a cochlear implant. So we had the wrong cochlear implant, all the checks were validated, and I put the wrong implant in the patient. And fortunately, they said, well, I like the red box anyway. And they went on with the Med-El. I'm like, holy crap. So we said, how did that happen? So we actually put a camera on a cochlear implant box at the loading dock where it landed, and we traced it till it got to the operating room. Guess how many people touched that cochlear implant in the hospital? 32. Yeah. And so what you realize is when you're in the operating room and you're pitching a fit because something isn't there, you are not even the tip of the iceberg. There's this whole process of getting that into the operating room that, depending on how big your facility is, if you can understand that process and know how to prime it, the error rate really drops. And Swedish has been very, very committed to that. And we really do have a mixed schedule. I mean, we'll do exactly that schedule I just said with Scott, and that's not all that uncommon. What are some things, for just starting with Leigh moving down, that you would want to just say, like, if you could make your life better at what you do in the operating room, what would it be? What's the two most important things?
Well, in our schedule, we have a place to write equipment needs. And because it's me and Reggie, for all the cases, we seldom have a different person coming in, maybe once or twice. But knowing that we know what your implants are, but somebody new coming in, they have to rely on the schedule. And currently, we don't write any special needs on the schedule for ear cases. So your implant needs to go on there. We know NIMS, we know microscope, we know tower. Stapedectomy, we know laser, but somebody fresh might not know that. So those things would be nice to have listed in your special needs when you put your cases on. And then two, to have the team keep a really updated preference card. So if things changed, change it, because that's what we go. We go get our 5x7. If somebody's coming in that's not familiar, they are going to follow that. That's their Bible. So to know that information, that what you guys need, and for me to translate it onto a card so I can share the information when I go on vacation and somebody's not shaking in their boots, they don't know what to do. So,
Reggie, what's the two things that are most helpful to you?
Exactly what Leigh just said. I need to know what you want. That's my biggest thing. I need to know exactly what you want and make sure we have it here. And if it's something special, I need you to let me know at least a week ahead. or the previous week what you want, so we can call reps and we can do the stuff that we needed to do. In the day of surgery, just talking to me in the beginning, just let me know exactly what you want, third case down, and we can get everything for you. The biggest thing is most doctors don't talk to your techs. You probably don't know who your techs are, but you guys got to get in the room and meet your tech and talk to them and tell them what you want, and that will help you out a great deal.
I agree. It's the schedule is like our recipe, and if you are missing one ingredient, we know it can flop. And so, the more clues you can give us, the better off your day is going to go.
So, I was talking to Alex this week. We had a busy day. We did 3 acoustic neuromas on Tuesday. And, that's kind of a great day for neurologists. I had 3 acoustic neuromas, and I went home and I just stuck my head in a blender because I got my butt kicked 3 times by tumors. They were just tough to take out. Patients did fine, but it was just tough. And there's some days you're a good doctor and you're a bad doctor, and I go home and I think through all those, I think through every case. I literally do pull out a skull, like where was I? Where did I get lost? I open my anatomy books. So when you're in the OR and you're running the OR and a case goes bad or a day goes bad, what do you feel like?
You already don't want to know that.
Well, I walk home, so I kick trees on the way home. So, yeah.
But it's very important to you the case goes well.
Oh, we feel bad. We feel lousy. Yeah. We're there to make you guys succeed.
Reggie?
Well, I feel like when you succeed, we succeed, just like Scott just said. So when the day goes great, you go home and you relax and you go walk your dog. At least I go walk my dog. And I just hang out and I have a great evening. And then I come back the next morning and whatever type of surgery I'm doing, I do. But when a day goes rotten, and if it goes rotten at the beginning, it just ruins the whole mood and everybody is not happy. And so no matter if you try to get back onto the good side, you still have that little bit of edginess that your day was rocked in the beginning, and I just felt that that's my problem.
Well, I'm always one that tries to assess where did it go wrong and how can we prevent that next time. So, there's a lot of factors in the patient going to sleep, and if they stay asleep, and if they're, things go well during the case. Sometimes it seems like the propofol is not working and everybody's starting to move. And so that kind of sets you up for can we get the patient still? It's at a point. And I'm the anesthesia tech as well in the OR, and it's great that we're getting things torn down and we're ready to go, but I still have to pay attention to the patient. I still have to be at the anesthesiologist side and not be taking care of all the other things I'd like to be taken care of when I'm needed at the bedside. So that's where they step up, but I always want to say, where did it go wrong and what can I do to make it better? So we talk about it. We talk about it. It's not that we're looking to blame, but we're looking to improve, so.
It's interesting that, I try to know all about the equipment in the operating room that I can, but there's just too much equipment to know. And like Scott is always a great resource for me, and in particular with things like the CUSA, which is the ultrasonic desiccator that we take acoustic neuromas out with. And sometimes I'll look at Reggie and I'll say, what do you think, Reg? And he thinks I'm kidding. I have no effing idea what to do next. And somebody in the room's got to have a good idea because I don't have one. And I think that, what I've learned over time is I'm slightly high energy. And I think like 2 steps ahead of most of the universe. And for the first 10 years of my career, I couldn't understand why everybody wasn't there. And after a lot of coaching and counseling and my wife telling me I was an idiot, I kind of realized that. But you also realize that your team in the operating room, in other dimensions of the case, are 2 steps ahead of you. And I think it's kind of a classic scenario where and a team is not a group of people. A team is people that get together, and 1 + 1 = 3.5. And I think that's what happens in the operating room when you have a relationship with your team, and the relationship is based on a foundation of respect and the fact that they actually do know a lot about things I don't know. And I think that's when it becomes very powerful for me. So I just throw open to any questions in the audience. If anybody have any questions they'd like to throw at them before we kick them off the podium? Alex, you have to have a question. You're the fellow.
I guess what's your least favorite thing about preparing for a case that if you had a surgeon who wanted to be more involved in trying to help you would make your life easier?
So what case, when you want to have a surgeon involved to help you get started, I guess what you're asking is, what case would that be, or do you want him just to step aside and let you take care of it?
The thing I don't like being not prepared for is if we're going to use the laser, because we keep a fiber and we test it ahead of time. So if I don't know it's a stapedectomy, and then it's like, we need the laser, that gives me anxiety. So I've gotten more comfortable with a laser. In the beginning, it was a definite anxiety moment. But I don't feel like that's something I should expect either of you to do. So advanced warning that the laser is going to be possibly used really lowers my anxiety level. And I really love that you help us clean up, take the drapes off in that. But, you know, occasionally all the schmutz or bone shavings go to the ground, and I'm like, oh, Dr. Backus, thanks for helping, but now I got to clean the floor. So, you know, that's the other thing, just being aware of what's getting dragged off the field when you
But that's
do
why I
help
blame
us.
Alex. That's what it is. Reggie, what about you?
My thing is just that help that you do give us in the beginning. You know, that I can't ask any more than that, especially on a busy day. So just that little bit of help at the beginning and the end. But other than that, I really have no issues.
Yeah, I think we're here at Swedish, we have a little different situation. We have more people to help us and stuff. So, but it's so nice to have the fellow come in, and we just want to pick their brain for a minute, you know, and make sure we have what we're setting up for. That's our most important part.
So my question is for we like everywhere, I think there's been a lot of kind of people exiting the healthcare workforce, and so there seems to be a little bit more of a revolving door of OR personnel and all personnel essentially. What, you know, I guess I'd want to know what information, you know, should be relayed to people who, you know, circulating staff and surgical technicians, specifically about getting to more facile at doing ear cases. Like, well, how can we help with that?
Well, hopefully the previous team, before they've exited, have written down all the information they have on a preference card, because that's really what the new person has to go by. And if they can be comfortable in saying, hey, I'm not very knowledgeable, if you can give me heads up for equipment, different things we're going to do. And when you have it hooked up to the television and you explain what you're doing in there, as a circulator, you know, I'm doing all this other stuff, but when I have time to actually watch, see what they're using the 5 cutter on, see when they switch to the, you know, 2 fine diamond, and know what's happening at that point. I love the teaching aspect of it, so I need to pay attention more, and if they're willing to teach your staff, that would be excellent. But really, it's got to be written down, because the second somebody says, I'm not coming to work tomorrow, and you're like, I've never done this before, they've got to have a preference card. So
Scott, we actually had a domino effect about 6 or 7 years ago where a bunch of staff left. And what was the key point in that? Was it just things were so disorganized people couldn't get their bearings in the operating room, or what was that?
No, it was a shortage of staff. People in general down there in the basement enjoy working there.
Mic up.
Oh, I'm bad at that. Enjoy working there, but it was a staffing issue when you continually are told, I don't have anybody to get you out of the case. Can you stay? And that, sure, everybody will do it once in a while, but over and over again, it burns people out, and they're looking for a better situation. And one thing more I wanted to say, I maybe said this already, but I think if I were you guys, I would grab your PLs once in a while and look at them yourselves and update. I've had docs look at their PLs and say,
What's PL?
Preference list.
Preference list. Your
And-
cards in the OR.
Yeah, and say, I don't use that, do I? And, you know, a lot of those don't get updated like they should. If you would grab your, and look at it once a year, you know, because you change things, and talk to Nikki, whack that out, put this in there, your day would go so much better.
One thing that would have answered Alex's question about not a specific case, but things that get under my skin is if you are not realistic with the amount of time it's going to take you to do the surgery. If you err on the lesser time and you always go over, your staff knows, oh, that's not going to take 45 minutes, that's going to take 90. But if you have your schedulers book it that way, it just backs up and patients are waiting and waiting and waiting. And that's what makes us feel the worst, is when the patient's sitting there 2 hours past their start time because this case took longer. Now, I understand when it's not scheduled and it turns out to be a more difficult case. But we've all worked with people that have always underestimated how long it's going to take. So just be realistic. If you know it takes you usually 3 hours, don't put 2, put 3. So that way you can be kind to your patients and how long they're going to be sitting there. So.
Yeah, as it was phrased to me by a haberdasher at Nordstrom's when I was buying clothes about 3 months ago, don't buy pants in the size you hope you might wear. So I think it's awesome that you all took time to come and be part of this. And, you know, I think you come into an ear course to learn techniques, you walk out to do better ear surgery. And I think this is a huge part of that. So thank you.